Now let us discuss the physical and chemical injuries of the oral cavity. So in this chapter we will discuss the injury of tooth that are associated with the tooth preparation, what are the effect of restorative material, effect of cement base, cavity liners, varnishes and primers, effect of cavity sterilization agents, what are the physical injuries to the teeth, to the supporting structures, to the bone, to the soft tissue, the radiation injuries, the electrical burns, the chemical injuries of the oral cavity, or the occupational injuries of the oral cavity. The teeth, as we know, particularly the dentine and pulp, they are not injured only by the dental caries, but they can be injured from those procedures necessary for the repair of the lesions involving the dental hard tissue, like preparation of teeth for receiving the restorations, that procedure involving cutting, grinding, etching with the So what are the effect of the tooth preparation? The tooth preparation, it is usually done with the rotary instruments like tungsten carbide burr and diamond burrs. Lasers and air abrasive, they are used alternatively. The pulpous response to these procedures depend upon the heat generation by the friction, the cutting of odontoblastic processes and drying of the dentinal tubules. So what is the effect of heat? The reaction of heat to the dental pulp is important, as we know that extraordinary amount of heat that can be generated by revolving, cutting and grinding instruments that are used in tooth preparation. Around 700 degree Fahrenheit temperature is recorded on the cutting surface. So these thermal changes, they are influenced by the size, shape and composition of the burr, the speed of the burr, the amount and direction of the pressure applied, the amount of moisture in the field, the length of time that burr is in contact with the tissue, and the type of tissue being cut, that is either it is enamel or the dentine. What are the effect of restorative material on the teeth? Zinc oxide eugenol cement, we used zinc oxide eugenol cement as a temporary filling material or a root canal sealer. So it has a liquid component, the eugenol, that fixes the cell, depresses the cell respiration and reduces the neural transmission. It is seen that the zinc oxide eugenol, it is least injurious of all filling material to the dental pulp. It has a sedative effect on mild damaged pulp, as it inhibits the synthesis of prostaglandin and leukotrienes. So which material are preferred for over-injured pulp or as a base in deep cavity preparation? We can use zinc oxide eugenol as a material of choice. Next comes the silver amalgam. The dark color metallic component of silver alloy turns the dentine dark grey. So you may see the tooth may be discolored. The amalgam restoration, when contact with the gingiva, it will cause inflammation because of the corrosion product and the dental plaque. You can see galvanism while using two different materials during the cavity preparation. The glass ionomer cement, it is most biocompatible and is widely used for filling and lining materials. It is also used as a luting cement. The biocompatibility of glass ionomer cement is due to the weak nature of polyacrylic acid. You can see pulpal plane that may be seen for a short period after the filling of the cervical cavities. This is due to the increased dentine permeability after the acid aging. We can use cement bases, cavity liners, varnishes and primers. So these all serve as a bacteriostatic agents, provides thermal insulation under the metallic restoration, particularly under the metallic restoration, to provide electrical insulation, to prevent discoloration of the tooth structure, to prevent the penetration of deleterious constituent of restorative material into the dentine and pulp to improve the marginal seal of certain restorative material by preventing the micro leakage and prevents the ingress of saliva and debris along the tooth restorative interface. Now let us discuss about the physical injuries of the teeth. The first is the bruxism, or it is known as night grinding, or other term is bruxomania. What is bruxism? Bruxism, it is defined as it is the habitual grinding or clenching of the teeth either during the sleep or during the waking hours. So bruxism, it is the one of the most common sleep disorder. So what are the causes, what are the etiology of the bruxism? That could be either local, systemic, psychological or occupational in nature. The local factors that could be due to the mild comfort, mild occlusion disturbance. So what you see is in a patient with bruxism, the patient engages itself in typically in the grinding or clenching motion during the sleep or when is subconscious when awake. So what you will see is there will be grinding or grating noise. So the bruxism, it can have an effect on the dentition, effect on the periodontium, effect on the masticatory muscles, or effect on the TMJ, or psychological and behavior effect. So on a patient, chronically bruxism patient will have severe wearing or attrition of the teeth. Not only the occlusion wear, but interproximal wear may also be seen. So ultimately what you will see is the sensitivity. On the both surface you will see facet that may be worn in the teeth. As bruxism continues, there may be loss of integrity of the periodontal structure that results in the loosening or drifting of the teeth or even the gingival recession that is accompanied with the alveolar bone loss. What next is the temporomandibular joint disturbances that are continuous to occur as result of traumatic injury. Hypertrophy of the masticatory muscles, particularly the masseter muscle, that will cause trismus, altered occlusion, and there will be difficulty in opening and the closing pattern of the jaw. So this bruxism will finally give rise to facial pain and headache. So if the underlying cause of the bruxism is emotional one, the nervous factor must be corrected. We can use removable splints that should be worn at night to immobilize the jaw or to guide the movement so that periodontal damage is minimum. Recently, it is seen that botulism toxin or the Botox has been successful in treating the grinding and clenching of the bruxism. So you will inject the Botox toxin into the masseter muscle that will weaken the muscle enough to stop the grinding and clenching activity. So if the disease is left untreated, you will see severe periodontal and or TMJ disturbances. What are the injuries to the sporting structure of the tooth? The first is the concussion. It is produced by injury that is not strong enough to cause serious visible damage to the tooth and the periodontal structures. On clinical examination, what you would see is the tooth may not be mobile or displaced from its original position. The crown will appear normal and patient will not feel any difference in the occlusion. The pulp that will give normal response to vitality test, but there is increased sensitivity of the tooth to the percussion from any direction. The treatment is selective grinding of tooth to eliminate the occlusion forces. Subluxation. It refers to the abnormal loosening of tooth without displacement due to sudden trauma. The tooth is mobile and sensitive to percussion and occlusal forces. The rupture of periodontal ligament is generally seen by the bleeding at the gingival clavicular margin. Avulsion. What is avulsion? It is the dislocation of the tooth from the socket due to the traumatic injury. It can be either partial or total. Partial avulsion includes intrusion, extrusion, facial, lingual or palatal or lateral displacement. The avulsion it is accompanied by fracture of the alveolar bone. Partial avulsion it is managed by reposition of the tooth and stabilization with the splints. Completely avulsed tooth can be reimplanted in the socket. Tooth ankylosis it is the fusion between the tooth and the bone that occurs most commonly in the deciduous dentition and can be seen in permanent dentition. Ankylosis. So, if there is extensive area of the root involved, what you will see is there will be a dull muffled sound on the percussion rather than the normal sharp sound. So there is no treatment for the ankylosed teeth that will undergo root resorption in the course of time. Now let us discuss about the physical injury of the soft tissue. First is the linea alba. So what is linea alba? Linea alba it is a white line. It is a white line that is seen on the buccal mucosa. The white line seen on the buccal mucosa that is seen posteriorly at the level of the occlusion plane. So this figure represents the linea alba. So why it is caused? It is caused by physical irritation and the pressure that is exerted by the posterior teeth. So it is usually bilateral and pronounced in person who have clenching habit or history of the bruxism. So histological what you will see is hyperkeratosis and intracellular oedema of epithelium that is easily noticeable. Second is the toothbrush trauma. So toothbrush trauma that will occur to the gingiva and is produced by the toothbrush. So what you will see, it appears as whitish, reddish or ulcerative lesion or linear superficial erosion involving the marginal or attached gingiva of the maxillary canine and premolar region. So you can mistake this toothbrush trauma for the vasculobullous lesion or infectious lesion if the history is not taken correctly. Severe form of toothbrush injury, what you will note is the patient showing the clefting of gingival margin and can show the gingival recession. In the severe form, you will see notching of the tooth and loss of the alveolar bone. So patient can come and presents with the pain and the burning sensation. So this type of injury is generally caused by the faulty toothbrushing or rabid or aggressive practice of the cleanliness. Next can be toothpick injury. So this toothpick injury is result of overzealous oral hygiene practice. So it will involve the interdental gingiva. The treatment consists of medication to relieve the symptom and teaching the proper brushing technique or the flossing technique. Other is the traumatic ulcer. What is the other name of traumatic ulcer? Decubitus ulcer is the other name of the traumatic ulcer. The traumatic ulcer of the oral mucous membrane itself says that it is caused due to some form of trauma. What could be the trauma? The injury that can be due to the biting the mucosa, the denture, the orthodontic appliance, toothbrush injury, exposure to the mucous membrane, or any sharp tooth or carious tooth that may injure to the mucosa by some external irritant. What is cotton roll injury? The cotton roll injury is common reaction when the dry cotton the roll is placed by the dentist while the treatment and is roughly removed and the mucosa adhering to it gets torn. So what are the common site of traumatic ulcer? They are most common on the lateral border of tongue, usually after the injury in which the patient severely bites the tongue. These ulcers are also seen. They are, however, more common on the buccal mucosa, on the lips, and occasionally on the palate. So, in the case of traumatic ulcer of tongue, that will resemble a close resemblance to the carcinoma. How will you manage the traumatic ulcer? So, the management of traumatic ulcer that consists of treating the symptoms. However, the ulcer will heal promptly when the irritant is removed. Next comes the traumatic ulcerative granuloma with stromal eosinophilia, or it is known as eosinophilic ulceration or traumatic granuloma. It is renamed by the word TUGSC that represents the eosinophilic ulceration from more aggressive lesions. So it is a reactive, benign, asymptomatic, self-limiting lesion of the oral mucosa. So it may resemble like a squamous cell carcinoma at the times and associated with the trauma. What is the pathogenesis of this disease? It is probably the T cell mediated. The trauma may be due to the Malpose teeth or the partial denture. In the infant, you can see the erupting teeth may cause sublingual ulceration, that is referred as Riga Fede syndrome. So these ulcerations may occur at any age, but more common seen with the males. It is common in anteroventral and the dorsal surface of the tongue. These lesions may be observed in other sites like gingiva, palate, and mucobuccal fold. These lesions, these ulcerations may persist from week to month and resembles just like traumatic ulcers. The treatment is as similar as the traumatic ulceration. The large eosinophilic ulceration that will heal rapidly after the biopsy, though extraction of involved tooth can sort out the problem, as in case with the Riga Fede disease. The teeth should be retained only if they are stable. Next comes the factitious injuries. They are the self-induced injuries that can be due to the number of factors like cheek biting, lip biting, etc. So these other name is Morsicato labiorium, Morsicato buccarium. So these injuries are habitual or psychogenic. So what you will see is biting and tearing of epithelium of the lip, buccal mucosa, or the tongue. Patient, what they do is they generally chew their cheek or cause stripping of the epithelium using fingers or creating negative pressure by sucking the lips and cheek. So such type is seen in patients who are under psychological stress. The habitual gingival injuries in which the patient presses the attached gingiva with her nails or forces the free gingival margin apically. So these type of lesions are usually bilateral and seen along the occlusion line and on the vestibular surface of the lips. The mucosa will appear white with area of redness. Ulceration is more common. This condition is more seen in females. So on histological examination, you will see extensive area of hyperkeratosis with keratin projections that represents the ragged areas. Treatment consists of counseling and psychotherapy and acrylic shield that can be used to prevent the access of teeth to lips and the cheeks. The next we are going to discuss is the denture injuries. As we all know that the oral mucosa, it is subjected to various kind of injuries as a result of wearing of artificial denture. So these injuries may be specifically as number 1, traumatic injuries, generalized inflammation, inflammatory hyperplasia, papillary hyperplasia of palate, or denture base or allergy. So let us discuss them one by one. The first comes the traumatic ulcer. that is also known as sore spot. So the traumatic ulcer, it is caused by denture irritation. So it is a kind of physical injury. This denture ulcer, it develops within a day or 2 days after the insertion of the new denture. So why it occurs? It occurs due to the overextension of the phalanges or the spicules of bone that are present under the denture or a high spot on the fitting surface of the denture. So these ulcers will be small, painful, irregularly shaped, that are covered by delicate grey necrotic membrane. So what is the treatment for this traumatic denture ulcer? The treatment of this traumatic denture ulcer, it consists of correction of the underlying cause. Now what is the cause? The cause, it could be the overextension of the phalanges, that is corrected by giving the relief to the phalanges, or the sequestration of the spicule of the bone under the denture. So that can be corrected by removal of any tiny sequestrum, or there could be the high spots that are present on the fitting surface of the denture. So we can correct them by giving a relief of giving them a relief of these high points. So when the cause is removed, the ulcer will heal promptly. Second comes the generalized inflammation, that is the denture sore mouth or denture stomatitis. A denture sore mouth is an uncommon condition that occurs in patients who may or may not have a new set of denture. Some cases of denture sore mouth, they are related to the infection with the Candida albicans. So the poor denture cleanliness is associated with a severe inflammation. Other causes can be continual denture wearing, poor oral hygiene habit. Now what will be the clinical features? The denture beneath the mucosa will become extremely red, swollen, smooth and painful. Severe burning sensation may be seen. The redness of mucosa is rather sharply outlined and restricted to the tissue actually in contact with the denture. Now what comes under the treatment part? In the treatment part, you can give antifungal therapy. In the antifungal therapy, you can consider nystatin tablet that are allowed to dissolve in the mouth 3 times a day for 14 days. That will treat the denture stomatitis. With the nystatin powder can be placed on the fitting surface of the denture 3 times a day. That will give good result. In case the denture fits poorly, then the construction of new denture can be made. Third is the inflammatory hyperplasia. What is the other name of inflammatory hyperplasia? It is Epulis fissuratum or denture injury tumor. So in this disease, what you will see, a ill-fitting denture will cause hyperplasia of the tissue along the denture borders. So such hyperplasia of the oral mucosa, it will be not restricted to this location, but it may occur in many areas. So in the inflammatory hyperplasia, what you will see is that there will be the denture injury, that is due to the result of denture injury, and it is characterized by development of elongated rolls of tissue. As similar, you will see a development of elongated rolls of tissue in the mucolabial or mucobuccal fold, into which the denture flank that will conveniently fits. So this proliferation of tissue is usually slow in developing, and it could be the result of resorption of the alveolar ridge that could be the cause of ill-fitting denture and causing the elongated rolls of tissue in the mucolabial or mucobuccal fold area. So in the histological appearance, what you will see is excessive bulk of fibrous connective tissue that is covered by a layer of stratified squamous epithelium that may be of normal thickness or show acanthosis. Pseudoepitheliomatous hyperplasia may be seen. Now, what is the treatment of this inflammatory fibrous hyperplasia? It should be surgically excised, and either a new denture shall be constructed or rebasing of the old denture shall be the treatment choice. If the denture is replaced or it is repaired, we will see that lesion will not reoccur. Next comes the inflammatory papillary hyperplasia, or other name is palatal papillomatosis. Papillary hyperplasia, it is unusual condition involving the mucosa of the palate. So it is associated with ill-fitting denture that permits frictional irritation and poor state of oral hygiene. This papillary hyperplasia, it will occur in the edentulous patient with the dentures. Constant wearing of denture is one of the most important factor associated with this condition. So what you will see is the lesion will present as numerous, closely arranged, red edematous papillary projection involving all of the hard palate and imparting as a warty appearance. So the treatment, there is no well recognized treatment. Discontinue the use of ill-fitting denture or construction of new denture without surgical removal of excess tissue will generally result in regression of the edema and the inflammation. The plasticizers of the soft liners, they can be cytotoxic and affect many cellular metabolic reactions. So a true allergy to denture based material, that is extremely rare, and these allergy that can be due to the sensitivity to the monomer that is both regular and self-curing type. Now let us discuss the chemical injuries of the oral cavity. So one of the most common reaction to drug or the chemical is the allergic phenomena. So that could be either drug allergy, that is called as stomatitis medicamentosa, or the contact stomatitis, that is also known as stomatitis venenata. Now let us discuss the chemical injuries of the oral cavity. The first is the aspirin. So aspirin, it is a local obtundant that is mistakenly used by many patients for the relief of their toothache, but they are harmful to the oral mucosa if they are applied locally. What you see is within a few minutes you will see the patient would see a burning sensation of the mucosa that will be noted, and the patient will see that his surface will become blanched, that is whitish in appearance. So the important feature is it causes separation and sloughing of the epithelium and frequently causes bleeding. So what is the feature of aspirin reaction? It causes blanching and sloughing of the epithelium after the local application of the aspirin tablet. Now what are the chemical injuries due to the endodontic material? Endodontic material would cause soft tissue damage resulting in the deep spread of inflammation, and necrosis may be seen due to usage of some endodontic material or their injections into the hard tissues. Now let us discuss these materials. The first comes the sodium hypochlorite. Sodium hypochlorite, it is the most common used root canal irrigant. Why? Due to its efficacy against the pathogenic organism and pulp digestion. So it is found to be sporicidal, virucidal, and has a greatest tissue dissolving effect on the necrotic than the vital tissue. So on the contact with vital tissue, what you would see is the sodium hypochlorite will cause hemolysis, ulceration, facial nerve weakness and necrosis. It damages the endothelial cells and fibroblast. Inadvertent injection of sodium hypochlorite solutions into the periapical tissue would lead to emphysema due to the oxygen liberation into the tissues. Gattaparcha. Gattaparcha is a biological inert material that is used to obturate the space inside the root of tooth during the endodontic treatment. This results in ineffective periapical periodontitis that is caused by extrusion of the gattaparcha. As there is transport of the bacteria beyond the apex, or due to incomplete cleansing or for the foreign body reactions. Hydrogen peroxide, on contact with the skin, it burns the tissues and releases toxic free radicals, so it should be handled with care. Next comes the sodium perborate. It is used as mouthwash, bleaching agent and in dentifrices. You will note that it will cause inflammation, edema and ulceration of mucosa can be seen with this. Next, the drugs that are used systemically. First comes the Dilantin sodium. It is an anticonvulsant drug that is used for the control of epileptic seizures. What is the effect of this Dilantin sodium on the mucosa? You will see it will cause hyperplasia of the gingiva. So gingival hyperplasia that will begin as early as 2 weeks after the Dilantin sodium therapy, and it will take 2 to 3 months. The first change you will note is the painless increase in the size of gingiva. So there will be enlargement of the interdental papilla. The surface of gingiva will show increased stippling, and there will be cauliflower gingival tissue that would be lobulated and cleft remains between each enlarged gingiva. On the palpitation, you will see that the tissue is dense, resilient, and insensitive. So this hyperplasia of the oral mucosa, it is entirely confined to the gingiva of the gingival tissue surrounding the teeth. So no treatment is necessary until the enlargement becomes aesthetically objectable. So the treatment part consists of the surgical excision. Discontinuing the use of drug will result in diminishing of the dimension of the bulk of the gingiva. Next drug is the cyclosporine. Cyclosporine, it is a selective immunosuppressant that is used in organ transplant patient to overcome the transplant rejection. So it will cause gingival hyperplasia as similar to as that of Dilantin. Another drug is nifedipine. It is a calcium channel blocker. It is used in cardiovascular diseases. The calcium channel blocker interferes with the production of collagenase through the altered calcium influx into the fibroblast. So what you will see is there will be gingival enlargement that would be seen 1 to 3 months after taking of this drug. The gingiva will be firm, nodular, and the clinical appearance is as similar as that of seen in Dilantin and cyclosporine. Next comes the lead poisoning. Lead poisoning, another name is plumbism. So for your entrance exam, the plumbism, it is another name for the lead poisoning. It is an occupational hazard because is seen due to the accident exposure. The chief mean of poisoning is through inhalation of the lead vapors or the dust. And in infants, the most common cause is ingestion by the child while chewing on wood painted with lead containing paint. So the lead intoxication is mainly manifested by GIT disturbances that will cause nausea, vomiting, colic, and constipation. A peripheral neuritis will also develop that will produce the characteristic feature like wrist drop or foot drop appearance. So the wrist drop appearance seen in lead intoxication. So formation of lead line is as similar as that of bismuth line. So there will be grey or bluish black line of the sulfide pigmentation that occurs in the gingiva. But it is sometimes more diffuse than what is seen in the bismuth poisoning. Excessive salivation and metallic taste are also common complaints. The treatment is secondary to the systemic treatment and prognosis. Mercury poisoning. It can be either acute or chronic. In the chronic mercurialism, that is characteristic by GIT disturbances, diarrhea, excitability, insomnia, headache, mental depression. There is increase in flow of saliva, metallic taste in the mouth due to the excretion of mercury in the saliva. The salivary glands that would be swollen, and the tongue is sometimes enlarged and painful. Ulceration on the gingiva, palate and tongue are most common. You will see deposition of dark sulfide compound. Lead lines may occur. Lines may be seen as similar as that of lead lines and bismuth poisoning. You will see deposition of dark sulfide compound. There will be loosening of teeth. What is acrodynia? Acrodynia is the pink disease or swift disease that is associated with the mercury toxicity. So that develops in the young children below the age of 2 years. Although children of 5 to 6 years may be affected. So the skin of the hand, feet, nose, ears, cheek, they will become red or pink, and the child will have cold, clammy feeling. The appearance has been described as resembling raw beef. So here sweating is the feature of acrodynia. There will be irritability, photophobia with lacrimation, muscular weakness, tachycardia, hypertension, GIT upset, stomatitis in the children, profuse salivation and dribbling. The gingiva will become extremely sensitive, painful, and showing ulcerations. So the treatment could be antidote. The antidote for mercury poisoning is dimercaprol or D-penicillamine. Tetracycline discoloration that may be seen in deciduous or permanent teeth. So what you see is there will be, so the critical period for the tetracycline induced discoloration in the deciduous dentition is nearest 4 months in utero to 3 months postpartum for the maxillary and mandibular incisors, and 5 months in utero to 9 months postpartum for the maxillary and mandibular canine. So what you will see, there will be, the child will have yellowish brownish gray discoloration, which is most pronounced at the time of eruption of teeth. This discoloration will become more brownish after exposure to light. The tetracycline, as we know, it is a fluorescence. It shows fluorescence under UV light, and therefore the teeth involved by this discoloration also show fluorescence under the UV light. Minocycline will cause discoloration of skin, nails, conjunctiva, bones, and teeth. So you will see a blue-gray appearance due to the black bone showing through the thin transparent membrane.